Many, right?
ใช่ค่ะ
Okay,
So
many.
for hip dislocation, there are two ways to like classify the types of hip dislocations. So like every other dislocation we've learned about, there's a simple complex classification where if there's an associated fracture, then it's classified as complex.
Mhm.
But for the hip, there's also the anatomical classification. So you basically look at the femoral head in respect to the acetabulum. So you look at the ball in respect to the socket. If it's anterior to the socket, then it's anterior dislocation. And then if it's posterior to the socket, then it's posterior dislocation, like the picture I provided on the right. I
Mhm.
think it's pretty clear. Okay, so etiology. So the most common mechanism that causes this hip dislocation is high energy trauma, and it usually occurs in young patients.
Mhm.
I'll get into more detail about this later.
Mhm.
And then for the pathoanatomy, didn't really understand this, but according to the ortho bullets, they said that the hip joint is sort of inherently unstable due to its anatomy and also the soft tissue that surrounds the joints, so like the labrum, capsule, and ligamentum teres. But yeah.
So many, what is difference between the shoulder and the hip? Actually, is the in dog is like the same, right? You have the shoulder and hip, right? So it's like the front and the back. So what is the difference between shoulder and the hip?
The ligamentum teres.
Yeah.
Because
The
they're
hip
both
joint, like you say, the hip joint stability is coming from the arches, is coming from the bone, right? Because the socket is deep. Okay. So when the hip dislocate, it never dislocate again. If you have no fracture, it's different from the shoulder. The shoulder, the socket is very shallow, right? And you have the labrum. Labrum act like the main stabilizer. It's the soft tissue stabilizer for the shoulder. Okay. So that's why when the shoulder dislocate, it will dislocate again because the soft tissue is the main stabilizer. Okay.
Okay.
Got it?
Yeah. I think I wrote it wrong on the sides, but yeah, I understand.
Next.
Okay, so we talked about anatomical classification, right? So for the hip, the posterior dislocation is the most common type, it's 90%. And the mechanism for this is usually a dashboard injury. So I provided a picture here. Basically, when you're sitting in a car, your hip is flexed and adducted. If your car crashes, there's like direct axial load on the femur, and I think you can tell from the picture that with the way the force is going, it's very easy for the ball to fall out of the socket. And then key thing to know is that the more flexed or the more adducted your knee is, like the less severe your injury is going to be. There's going to be less chance of fracture. I think that's might just be because it's like super close. ไม่แน่ใจเหมือนกันค่ะว่าทำไม
Yeah, if the deformity is obvious, like friction, adduction, internal rotation, like the first picture, that means this is a simple dislocation. Okay. But if you have less adduction, less internal rotation, that means it's not the classic dislocation. Most of the time, the socket is broken too. Okay. Because there's nothing to block the motion. You can, if the simple dislocation, the obvious deformity because the socket acetabulum is intact, you know. But in case the acetabulum is broken, the hip is will be not obvious deformity because it's now free. Okay, nothing to block it. Okay.
And then the complications that we need to know is that there's chance for osteonecrosis if you don't like reduce it in time. And there can also be like associated fractures, but there can also be sciatic nerve injury and ipsilateral knee injury. Then for anterior dislocation, I was able to find less about it. So the mechanisms for this are extreme abduction with external rotation of the hip, or if suppose your femoral head receives like a high impact, or you have chondral injury, so like cartilage injury. When I was looking it up online, examples they gave were also like car accidents, something like that, but it has to be in this position. And then there are two types. Not sure we need to know them, but there's obturator dislocation type and pubic dislocation type. And there will be like specific physical examination findings, as you can see in the description of the picture.
Yeah, is that common, the anterior dislocation or hip joint?
Not common.
Yeah, it's not common. So most of the cases I found is the injury from big bite. Why? It's big bite. Why? Saka, you have big bite, right? Saka have big bite in Mumbai. Saka.
I had, yeah.
You have a big bite, you show me, right? You also
Yes,
have some accident.
yes, sir.
But your hip is okay, right?
Yes, sir. Knee is bad. Sorry, ankle is bad.
Why big bite injury, anterior dislocation?
Sir, because mostly when you fall on the one contralateral side, ipsilateral side, sir, the hip is flexed and sir abducted and external rotated.
Yeah,
Because
in
of
big
the
bite. Big bite, you need to abduct, external rotate
Yes, sir.
like this, right?
Yes, sir.
Because it's
Right.
big. So
Yes,
you're
sir.
not riding like the woman motorcycle. You abduct your hip joint, right? For
Yes,
big
sir.
bite, you need to abduct, external rotate. So
Yes,
when you
sir.
hit something in the front, it will hit on your medial side of the knee.
Yes, sir.
Okay? So that
Yes, sir.
make your hip joint abduct and external rotate.
Yes, sir.
Does that
More.
like this? Okay?
Yes, sir.
So
Yes,
it's dislocate anteriorly.
Yes.
It's different from the woman motorcycle. You abduct internal rotate. When you have dashboard, the hip
Yes,
will
sir.
dislocate to the back. Okay?
Yes.
Many, you understand?
Yeah,
Okay.
I get the picture now.
You got it, right?
Yeah.
Very good.
Okay, so for presentations, pretty simple. Usually the patient will present with like three things: acute pain, deformity, and inability to bear weight. Pain is obviously because sometimes the dislocations is also associated with like tendon tear. And then I said earlier that it can also be associated with knee injury. So sometimes this pain also like radiates to the knee. And inability to bear weight, obviously the hip joint is a crucial weight bearer, so without it, you can't bear weight. And as for deformity, we sort of saw that earlier, where like a patient will present, depending on what sort of dislocation they have, they'll either present with like, internal rotation, abduction, or abduction and external rotation. Yeah, and then also like they can have like limb length discrepancy. So those are the key. And then so for a physical exam, the first thing you do, usually because this is trauma-related incident, you just do ATLS. And then for the physical exam findings, I already talked about it, but just to reiterate, if it's a posterior dislocation, the hip and leg will be slight flexion, abduction, internal rotation. Anterior dislocation is hip and leg in extension, abduction, and external rotation. The special thing about posterior dislocation, apart from like it's very common, is that it's associated with sciatic nerve injury and knee instability and knee injury as well. So for sciatic nerve injury, just don't forget to test ankle dorsiflexion, toe extension, and also just the sensory distribution. Yeah.
So the nerve atlas for the posterior dislocation is many?
Sorry,
The nerve atlas. What is the structure? The nerve. that may be
What?
damaged. The sciatic
Sciatic.
nerve, right? So how to test it?
For motor, I listed it here. So ankle dorsiflex and toe
Mhm.
extension,
Yeah.
because sciatic nerve branches into the common peroneal nerve.
Yeah,
But
there's
for
two.
sensory,
Yeah, there's two components, right? The peroneal part and the tibial part. But most of the
Yeah.
time, the peroneal part is more, vulnerable to injure, right? It's very sensitive.
Yeah.
So the patient will have foot drop if the nerve
Yes.
injury, foot drop. Yeah, so very simple.
Yeah.
So how about the anterior dislocation? You didn't mention in your slide.
Yeah. When I read up on it, they didn't say that it was particularly associated with
Yeah. So
anything.
what's the structure in the front? Which calf nerve? What
Which-
nerve in the front?
The common peroneal nerve is
No,
in the
no,
front.
no, no.
No.
You palpate your hip joint. What is in the front? You also can palpate the pulse.
Femoral.
Femoral nerve, right? It's next to the
Yeah.
femoral artery. So the nerve at least is the femoral nerve for the anterior dislocation. Okay.
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 Yes.
Very good. Next.
Okay. And for investigation that you can send, so I think it's only 2 X-ray views. There's AP view and lateral cross table. So the point of sending these, as I mentioned earlier, you can sort of tell from physical examination already that you can hypothesize what type of dislocation the patient has. So X-ray is just to confirm the anatomical dislocation, but you're also trying to rule out associated factors, because management will be different if there's a fracture. Okay. So this is like normal hip AP view. I brought like a labeled version and an unlabeled version. And the key thing when you're looking at the AP view is to compare femur head size. I think it's pretty intuitive, because if there's a dislocation, then the femur head will not be equal in size. If it's more anterior, then it will look larger. And if it's posterior, it will be smaller compared to the other femoral head. Yeah. And then the other thing you can look at is Shenton's line. This is like, it's just an imaginary border that you draw. So you draw from like the medial edge of the femoral neck to the inferior edge of the superior pubic ramus. And if it's a one connected line, then usually it's okay. There's apparently still might be a fracture, if that makes sense.
Yeah, this is the hip dysplasia, this picture. It's not the hip dislocation. This is a hip dysplasia. Okay. You can see some subluxation of the head, right?
Yeah.
That is also disrupt the cortic arc. Not cortic arc, sorry, Shenton line.
Yeah.
Okay, next.
So this one is disrupted. Yeah, these are pictures of the hip location. So if you can see, this one I said is a right hip posterior dislocation, because I think it's also, even if you don't measure the femur head, you can sort of tell like this is behind the acetabulum, but if you measure, this should be smaller than this side. And then Shenton's line, I think, is intact from my quick scanning. And then for the picture on the right,
intact?
I think so.
That's a normal hip is intact, right? But this one is disrupt, see?
Oh.
It's disrupt. It's not like Salah, you see?
I
You
see.
draw the line.
It's narrow. It's narrower.
Yeah, right. It's not like Salah, comparing to the opposite side.
Oh, I see.
And also disruption, okay?
Okay. Oh, and then for the picture on the right, it's a left hip anterior dislocation, I think, or is it close?
Yeah, you can see the lesser to canter. For the anterior dislocation, the hip internal rotation, you cannot see the lesser to canter, you see? It's gone. But on the external rotation, the anterior dislocation, you can see obviously the lesser to canter because the hip abduct and external rotate. Okay,
Yeah.
the lesser is in the back, so when the hip dislocate anteriorly, the leg external rotate, you can see lesser to canter.
Okay.
And
Yeah,
also
that
in
makes
hip
sense.
fracture, fracture neck femur, trochanteric fracture, you can see lesser trochanter or cannot see many
ถ้าเป็น
hip fracture.
hip fracture. Oh, you also. Maybe you can see if it's dislocated.
No.
ไม่แน่ใจ
So whenever in hip fracture, you go back to see the patients, or you can see in Google hip fracture. You always see the lesser trochanter because the hip external rotate, always external rotate, right? When you have neck fracture or
A
trochanteric fracture, okay,
Oh, okay.
and you
That
cannot
makes
see the
sense.
fracture line very well because when the hip external rotate, you cannot see the neck. Okay.
Okay. So I think you guys saw just now that like maybe with this one view, it might be difficult to tell if the head is like behind or in front of the acetabulum, which is
Yeah.
why they also do the hip cross table lateral view. Unfortunately, I could not find any pictures, so I just drew an arrow. So this is like normal hip x-ray. This is also normal, but I just drew an arrow to show like, okay, if it's posterior, then it would slide down.
Yeah.
And then for anterior, it would slide up.
Yeah. So most of
And
the
then-
time, you don't need to do that because the patient may have pain because just the AP X-ray is enough. Okay. Just because you can see the position of the hip. If the hip abduct external rotate, that is anterior. If the hip adduct inner rotate, that is posterior. Okay.
Okay. These are just the summaries of the X-ray findings. I talk about like you look to see whether the head is in front or behind of the acetabulum, and also
Yeah, that's
you can
enough.
compare.
I think you already mentioned. Don't need to take again.
Yeah, and now for the treatment, like I said before, the reason we did the X-ray is because we want to see whether or not we can manage it non-operatively. So if there's no fracture, then it's recommended to do an emergent closed reduction within 12 hours using either the Alice or Lefkowitz technique. I have videos of this later. And it's recommended to do it as soon as possible to avoid the complications that we talked about earlier, like the nerve injury, the sciatic nerve injury, and a vascular necrosis. And then these are just the operative options. So there's open reduction, and then you remove fragments, and there's open reduction, internal fixation, then arthroscopy. And okay, these are the videos for the close reduction.
Close reductions.
Okay.
So first you need to have assistant, right? You do that at ER or in the operating theater, many? Awake or not?
This one, I think you can be awake. You can do it in the ER.
No.
No?
No. You should not do that at the ER, okay? Because the hip joint is big joint, big muscles. You need full relaxation. Okay? It's the only joint that you cannot reduce at the ER. Okay? You must do it at the operating theater. Full sedation. Okay? So after full sedation, you need one assistant to stabilize the pelvis, right? And then, this is a big guys. So you grabs the, okay? Like that. See? It's very
and you use
strong.
your arm to spoon.
Yeah, pulling up and stabilize the pelvis. So that's the way. Okay, we call this Alice technique. Yeah, this is Alice technique. So another way is to use your knee joint Use your knee to put underneath the knee under the knee. Okay? Act like the falcon. Like that. Okay? And same, you stabilize and then push. You see that? Using this way is easy because you just push. Okay? And reduce the hip back that way. We call this left Kovics technique. So I prefer to use stick technique because it's very simple. Have you tried that, Saga? Cat CJ, the left Kovics technique?
No, sir, not yet.
No? Cat never? Saga,
No,
no?
sir.
I use
Okay.
Alice or Stimson, sir.
I used Alice.
So Cat, she did the hip reduction at the ER. I just back problem. Cat, you tell your story? Tell everyone your story.
Sir, when I was a first year resident, sir, I had a hip dislocation at ER. My senior told me to reduce immediately. So I reduced. I had HNP, sir. So I still suffer until now. I already had 2 minor surgeries. So that's why. After that, sir, never.
See?
All at OR.
So many you heard about her story, right? Do not do that at the ER. Okay?
Noted.
You need full sedation. Otherwise, you'll be like Cat.
Yes.
Yeah.
It hurts.
It's hurt, right?
Yes, sir.
Very good. So how about the after reductions, Manny? And how do you advise the patients? How you treat the patients after the reductions? You show us the reduction technique, right?
Yeah.
And what's next?
I didn't. I know that after you reduct, you have to like image it again to make sure that everything is in place.
So you image again, right? So what kind of image? How you order?
You can order the same X-rays, but I also read that you can order Judet, but I don't know how common that is. No.
Judet is for acetabular fracture. Okay.
Okay. And then
Judet, in
also,
case you suspect the acetabular fracture, you can order Judet, right? But for simple dislocation, after the reduction, you need to order
CT.
one hip or both hips.
I think both, because you still need to compare the head size.
Yeah, you need to not the head size. You need to check the joint space between the left and right side. Why? Why? Who can answer these questions? Prava, Win, Ingfa, England. No. So, CJ, tell the student why.
A common scenario when performing hip reduction, sir, is what we call an eccentric or a not perfect reduction. So it happens because since the hip is a big joint, due to the force needed to reduce it, sometimes there are loose bodies or small fragments that get entrapped in the joint after reduction. So you cannot see them perfectly, but a clue is if you take an X-ray and the joint is not perfectly reduced, that will increase your suspicion that there may be a loose body or a loose fragment that's causing it to be not perfectly reduced.
Okay.
So you always take it.
So always send the patient for both hips X-ray. Comparing the joint space, can you share the student the pictures of the incarcerated fragment? We call this loose body or incarcerated fragment inside the joint. So when you see the X-ray, the joint space on both sides is not equal. Okay, but if you take only single hip X-ray, you will miss it. Right, and this is the disaster. If you have loose body in the joint, what would happen? England.
It's like a foreign body.
Yeah, and finally,
Risk of arthritis.
yes,
Like-
it will be arthritic change
Inflammation.
very fast. You get arthritic change very fast. Okay, you have something, the bone inside the joint. Yeah, finally the joint will be destroyed by the wear and tear process. Okay, so very good. If you find the loose body in the joint, okay, share these students.
Yes, sir.
So after the reduction, you should advise the patient for the list of a vascular necrosis, okay, and also the protection for the dislocation. Try not to do flexion, adduction, interrotation at the beginning. Okay, very good. And another thing is that you need to test the stability. Many you forget to tell that. So after the reduction, you need to bend the hip to the 70 to 90 degree. Okay. Saka, can you find the stability test? Show the student. Okay. Bend the hip to a 90 degree and then push. Same mechanism. If the acetabulum is okay, there's no broken bone, the joint should be stable after the reduction, right? Cat, show that pictures again.
Show it.
Okay.
Can you see it?
Yeah, you can see that the joint is not, yeah, it's widening, right, on the medial side, and that some loose body in the joint. Okay.
Yes. It's supposed to be like this.
Yeah, it's supposed to be like this. You see the A and the C, right? The joint space is not equal. And I published the hip arthroscopy technique for the 7 cases in Thammasat many years ago, right? To do the arthroscopic loose body removal. Okay, because at that time, nearly 20 years ago, there's no hip arthroscopy in Thailand, right? I'm the first one to do that, to remove the loose body. It's a keyhole surgery, and comparing to open surgery, this is very safe. Because when I was young, I have done one case of the loose body removal. Do you know what happened to that patient? By
ABN,
open
sir.
surgery,
ABN,
2
sir.
years later, he had a vascular necrosis. Okay.
Very high rate, sir. Sir, what
Very
approach
high.
did you perform, sir?
Oh, I tried to do the at that time I was very young. I do the dislocation again and take the loose body out, because it's not easy to take that fragment out by open surgery. Okay, because it's very deep inside the joint. You cannot take it out if you don't dislocate it. Okay,
Posterior approach, sir.
the posterior approach, but actually you need to do anterior approach. Okay,
Yes, sir. Yes, sir.
because you have less vascular injury.
Sir, question. What about weight bearing after, sir? After a simple
You can put the weight on partial weight bearing for 6 weeks.
partial.
Yeah.
Okay, sir.
So that's a recommend. But I'm not sure that's true. That's true. Because in the book always said like that, partial weight bearing for 6 weeks. Okay.
Okay.